My name is Firas Abdollah, and on behalf of all the authors, I would like to thank BJU for giving us the opportunity to share our results and for selecting our report as the article of the week in November 2015. The objectives of our study were twofold. First, we wanted to identify patients with the clinically high-risk prostate cancer that would harbor favorable pathological outcomes at the time of surgery. And second, we reported on the long-term cancer control outcomes of these individuals and compared them to the outcomes of patients with unfavorable pathological features at the time of surgery. Our cohort consisted of 810 patients with high-risk prostate cancer that were treated with robotic-assisted radical prostatectomy and pelvic lymph node dissection between 2003 and 2012 in a single institution. Our endpoints were first to identify patients with specimen-confined disease that was defined as a pathological stage of T2 to T3A with negative margins and negative nodes. Second, we reported on the biochemical recurrence and cancer-specific mortality of these individuals. These were the descriptive characteristics of our cohort. As would you expect, patients with pathologically confined disease had lower PSA, clinical stage, and clinical grade at the time of diagnosis. When we used these covariates in a regression model, PSA, clinical stage, percentage of positive cores, and clinical grade were all independent predictors of harboring a specimen-confined disease. And the lower was the PSA, clinical stage, grade, and the percentage of positive cores. The higher was the probability of harboring a specimen-confined disease at the time of surgery. The coefficients of these independent predictors at the multivariable models were used to develop a nomogram that you can see here. It's really easy to use in clinical practice. I will give you an example of if the PSA of the patient that you have in front of you is 5, then this will correspond to 80 points. If his clinical stage is T2C, this will correspond to 15 points, and so on and so forth. You go and get the points that correspond to each of the predictors that you have in the model, and then you get the sum of the points, which in this specific case was 202, which corresponded to an 88% probability of harboring a pathologically specimen-confined disease. Here you can see the calibration characteristics of our model along with the discrimination, which was 76%. Both these parameters implies that the model performed well in predicting pathologically confined disease in our cohort. These Kaplan-Meier's shows the biochemical recurrence-free survival rate in the entire cohort on the left, and on the right, after stratifying patients, you can see that patients with specimen-confined disease had a biochemical recurrence-free survival rate of almost 73% at 9 years versus only 32% in these with non-specimen confined disease, and the difference was statistically significant between the two groups. The same trends were observed when examining cancer-specific mortality-free survival rate as an endpoint. In conclusion, we developed a novel nomogram to aid in preoperative prediction of specimen-confined prostate cancer at the time of surgery. Patients with specimen-confined disease at the time of surgery had favorable long-term biochemical recurrence and cancer-specific mortality-free survival rates following treatment with robotic-assisted radical prostatectomy. Our novel nomogram can be used to support clinical decision-making and to aid in the selection of high-risk prostate cancer patients who are most likely to benefit from treatment with surgery. Thank you.